Hello and welcome to the second topic of the CT methods section of this subject. So first we're going to talk about biopsy and interventional CT. So by the end of this, I expect you to know how you would go about localizing the needle location once the doctor has the needle in, and how you go about localizing the skin entry point. Okay. And it also expect you to know some basics about the more general procedures that you may encounter on a day-to-day basis. So first you need to think about what we're going to do pre-procedure. Okay, so it's very important you keep the patient at ease, and to do that you need to make sure you know what you're doing and you look like you know what you're doing. So have the room ready to go. Check the old films or images if it's a biopsy, so you know exactly what position you're going to need to put the patient in. Okay, the patient needs to be consented either by a nurse or a doctor. And if the patient needs to be changed, you should do that as well. Okay, for many biopsies, or nearly all biopsies and some procedures, you will need to check the clotting or the INR of the patient. Okay. So CT we use to localize the lesion, okay, because it can do it very accurately and quickly. It can help guide the doctor in with the needle. So the procedure relies on the patient remaining still for the entire time. Okay, so that's why it's very important that you position that patient correctly at the start. Not just in the correct position for you to put the needle in, but the patient needs to be comfortable. If they're not comfortable, they're not going to keep still. Okay, so use sandbags, sponges, pillows, whatever you need to do to get that patient nice and comfortable. So what we need to do is localize the where the skin entry point is for the needle for the radiologist. Okay, so there's several ways to do it, as you can see listed there. We have the radio-opaque grid, the radio-opaque catheter, local anesthetic needle, paperclip, and midline measurement. Okay, it really depends on where you work, which one will be used. Often the radio-opaque grid is used, and it is fantastic, but it is very expensive. You're looking at least $10 a grid. Okay, and they are meant to be single-use only. Okay, but I'm yet to see a place use some single-use at $10 a grid. Okay, I've seen places cut them in half and then reuse the halves over and over again. But think about it, if you're a patient, would you want that on your back after it's been on several other patients' backs? My answer is no to that one. And there are many other types of skin entry point localization, as you can see there. Okay, so we'll run through those just quickly. So this is your grid. What it does is it's basically like an A4 sheet of, not paper, but thin material that a Sharpie can go through. It has the radio-opaque lines all the way up and down it. And from there, you basically pop it over the patient in the area of interest. The doctor says, I want to go in at dot 5 from the medial side. So you go and you measure it. You make sure you have the correct end. You're measuring from the correct end, and then you mark the skin where they want you to. Okay, so you mark the paper grid and it goes through and marks the patient's skin. Okay, so you can see here this is a nerve root block, we've used it, and also on a foot joint injection. So this one's the local anesthetic needle. This is used a lot less because it's not quite as accurate. You're basically putting the needle in blindly and putting your local anesthetic in blindly as well. So they'd put the local anesthetic needle in, as you can see there, and then what they do is they take a picture on it and check the location and where they are and where they need to go. I really don't see that used much these days. A very basic one is just using a straightened out paper clip, as you can see here. You put the paper clip on the patient's skin, the doctor says, I want to go in over here, and it turns out it's 5 centimeters lateral to that paper clip. So you move the table into this position, because of course you know the table location, and then you take a ruler in, or you can use someone in the previous lecture suggested you could use one of those paper tape measures that they use for PICC lines and stuff. And you just measure 5.2 centimeters lateral to that paper clip, and then you mark the skin there. Okay, nice and easy, can be used. And it's very cheap as well. Obviously, the price of a paper clip, you don't have to keep reusing. You just throw it out each patient, you're good to go. So there are three main ways to localize the needle during the procedure. Okay, we have fluoroscopy, a standard basic axial scan, or a helical scan. Okay, so most these days we'll use the axial. Fluoroscopy will be used for more difficult procedures to help guide the doctor's needle in real time, or helical if you need to cover a large range of large area. So when we do a procedure, it's very important we keep the radiation dose low. They do not need to be diagnostic quality. You don't need to see fine details. Okay, you just need to see whatever structure you're heading for. If it's a nerve root, it's what you need to be able to see. If it's a facet joint, then you can give even less because it's easier to see bones. Okay, a little bit of noise doesn't matter. The lower the radiation, the better. So as we can see here, here's our epidural scan. Poorly windowed, but that's the way PowerPoint does it. It's a very grainy image. Pop the needle in, you see the needle tip, we're in the right position. Injects a bit of air, just to double check we're in the right position. You see there, the black. Obviously you'd widen the window and be able to see that a bit better. And that shows us in the right position with very grainy images, but that's all we need. There's no point in radiating someone. Remember the ALARA principle, as low as reasonably achievable. Okay, so for procedures that require breathing instructions, it's important you let the patient know what breathing instructions they're going to hear. Okay, make sure they know that it needs to be the same size breath each time. If they take a different size breath, that lesion might move superior or inferior from where you're expecting it to be. Sometimes, if the patient's having trouble holding their breath the same amount each time, you can use expiration. Okay, so if you breathe in, breathe out, stop breathing there. Okay, if you breathe out, it's out. Okay, there's no variations of expiration. It's pretty much consistent the entire time. Okay, so we measure the distance from the skin entry point to where the lesion is. Okay, so we need to tell the doctors how long it is, so the nurses can get the right needle out and the doctors know exactly how far they need to put the needle in. What slice thickness do we need to use? That depends on the structure. Okay, if we're doing an epidural, we need to get through that tight posterior epidural space or window there. It's very tight in some older people. You will need 1 millimeter slices, but if you're doing a nerve root, you can get 2.5. Remember, the thicker the slice, the less radiation you're going to need to give. Okay. So after the procedure, okay, take an image showing where the final position of the needle is. Okay, you need that artifact, a beam hardening artifact at the end of the needle to show that that is the tip. Okay, medico-legally you will need that. Different procedures require different post-procedural care, okay, for the patient. It's important you know it as well as the nurse, just in case you've got a different nurse who doesn't know, hasn't done it before. Just a quick overview of some the basic procedures. So we'll just do a basic biopsy or FNA. So we use it to obtain a tissue sample that we can use to determine cell type, so they know what type of treatment, or if it's a cancer, or if it's infection, things like that. Okay, so we can do a core biopsy. Okay, we've got a spring-operated needle cutting a sample of the tissue and extracting it back in the needle. So you got your needle, shoots out the like a little scalpel, cuts it, and brings it back into the needle. Okay, then you get that little sample inside the needle. Okay, FNA, they pop the needle in and then they pop a little syringe onto an extension tube, and they just suck the syringe back and forward and just try and suction a few cells of the lesion into the needle. Here we can see an example of a lung lesion we were going to biopsy. We've done 3 measurements here. These are important. Okay, so skin edge to the pleura. Okay, you want to do as fewer passes as possible through that edge of the pleura. The more passes you do through there, the greater the chance of getting a pneumothorax. Okay, so you do one just before the radiologist, an image just before the radiologist hits the pleura. So we've got that measurement, we know how far they go in, just to check they're heading towards the lesion. Just say they put the needle in and it was heading out this way, heading medial, and they say, okay, that's heading in the wrong direction. So we'll straighten that up, make sure it's heading straight before we proceed through that pleural space. Okay, we need to measure the start of the lesion, obviously, and the back of the lesion. If you're doing a biopsy, that needle, the scalpel part of the needle springs out from the needle. You've got to make sure. I mean, imagine if we put the needle here and we spring through and we hit this pulmonary artery, if that's what it is there. That's not good. You don't want to be rupturing anything behind the lesion that you're biopsying. Here's an example of one that's gone through the other side. There's a bit of a pneumothorax which may have caused that. Okay, there's nothing there major that it could hit. So we've got a little pneumothorax there post-biopsy. Another pneumothorax, just heading in the lesion. We said lesion tip, or the needle tip, sorry, because we've got that beam hardening artifact. And here we can see a biopsy done well. Okay, we've got the throw there, grabbing our samples, grabbing it back in, and here we've got a bone biopsy. Okay, another basic procedure you'll see quite a few of is a CT nerve root block. We use it to relieve or control the pain, most often caused by disc-related issues. Okay, they'll have a small disc prolapse or something like that. Okay, we can perform it at any level of the vertebral column, cervical, thoracic, all the way down to lumbar. Most common it will be performed in the lumbar. We'll use 2.5 mm slices with a soft tissue algorithm. Okay, we don't need to see fine details, 2.5 is enough. Here's an example. We can see the needle tip coming in here. This is our nerve root block. Okay, nice grainy image. This is where the nerve comes out, exiting nerve root foramen. And here we've got a cervical nerve root, where the nerve comes out here. So we'll pop the needle in just behind it, inject a little bit of contrast to check the contrast flows around where the nerve is before we pop the stuff in to kill it. So the back pain, originally originating from degenerative or inflamed facet joint, okay, is often treated with a facet joint injection. Okay, so we use some corticosteroids and local anesthetic into the joint. This will use 2.5 mm slices again, but we'll use a bone algorithm and bone window this time. Okay, because I mean that's all we're looking at, bone. Okay, it's important you know the difference between the two. So you select the right protocol or create the right images before the radiologist gets in there to mark up the patient. Obviously there's our bone window. We're heading into a degenerative facet joint there. This was bilateral, obviously this is from a different needle, and that one's heading into that one there. That must be it there. Okay, very degenerative facet joint there. See, our bone window is still a very grainy image because we don't need that fine detail in the high radiation dose. So the epidural is normally performed when there's multi-level issues, so multi-level disc issues. We pop it in the epidural space of the spinal cord. So we're normally from about L3 down. Okay, the needle is advanced past the ligamentum flavum at the back, and we confirm the location as we saw before. We inject a small amount of air, and we'll see that congregating underneath that ligament, and that way we know we're in the right spot, and then the doctor can inject their corticosteroid. Okay, thin slices, we do need thinner slices, 1 to 1.25 with a soft tissue algorithm so we can see that epidural space accurately. So we can see here the needle going into the, so our space is here, see the little fat plate pad there, that's where you want to put it. Inject some air, we can say yep, it's in the right spot, good to go. So in conclusion, you will need to know those pre-procedure steps we talked about. Planning and positioning the patient. Okay, locating the needle. Okay, and locating the skin entry point. And how we scan during the procedure. Okay, post-procedural care, it's important you know the basics of, say, a nerve root block, an epidural, and a facet joint. Okay, and maybe a lung biopsy as well.